as other diseases are specific for women, hypertension also has got some specific risk factors. So as we can see that hypertension, it's a key risk factor for cardiovascular morbidity and mortality in women. The risk factors which are established are more or less same for men and women, which are unhealthy diet, lifestyle, obesity, and aging. However, there are specific female risk factors which are almost now understudied, or we can say that underrepresentative in the hypertension guidelines when it comes to women. So we all know that until menopause, women are assumed to be protective against these cardiovascular diseases because of the hormone estrogen. But we need to have more detailed analysis and guidelines, and maybe some clinical studies which have some impact on the various risk factors which are present, which are specific to females when it comes to hypertension and cardiovascular morbidity and mortality. So when we see the epidemiology, you can see in the graph that as when people are less than 30, be it a men or women, younger men have a higher mean blood pressure, which can be seen in the graphs on the right hand side. But as we see that between 40 and 60 years of age, especially between 40, when there is a pre-menopausal age, then the rise of BP can be seen more in women as compared to men. And by the time they turn between 60 and 80, it has increased. So is with the systolic blood pressure, diastolic blood pressure, and the mean elevation, mean arterial blood pressure map, which we see. It is their elevation from the baseline as compared to women as in men. So, like already said, the prevalence of hypertension in aging women, it is higher in men as compared to age-matched people, at least to the tune of 40%. And when we see at the global prevalence, the hypertension among women and men between 30 to 79 is approximately 32% and 34% respectively. So when we talk about the diagnosis, treatment and control rates among men and women, so it is seen that when you can all see that 59% females are more hypertensive as compared to men, and the treatment control is also a little bit poor. So when we talk about the pathophysiology of hypertension in females, almost it is similar except for the few points. We all know that when women tend to live a little more longer as compared to men, but eventually when they grow old, women experience more frailty and ill health. So there are few pathophysiological factors like gynecological disorders, adverse pregnancy outcomes, obesity, hypertension, which are more prevalent in women. And we can see that initially in the few years before the premenopause, the physiological level of estrogen has a cardioprotective and uh, cardioprotective effect in females. Now, what does estrogen does? So, estrogen, they are cardioprotective. They reduce the cardiomyocyte oxidative stress. They reduce the ischemic and hypertensive stress, which is produced by the vasodilation in the peripheral vasculature and coronary arteries. So, after menopause, what is happening is when the estrogen level goes down, these female patients, they are more prone to what is you call as the sodium sensitivity, which is seen more so when the estrogen goes down. Other inflammatory disorders, like we already discussed in today's topic, the autoimmune diseases which are prevalent more in women, they also cause a little bit of occurrence of hypertension and CVD in women. Also, there is a greater expression in compared to male, when we can see that there is a greater expression of the RAS endothelial system in females as compared to men. However, it gives a protective effect to females. But as the estrogen goes down, the sodium sensitivity increases, and hence the more chances of hypertension in females. So, the topic more or less for today is the risk factors which are specific for females. So, as we can see in this diagram, so the social factors which we need to consider obviously is the sexism, age, racism, poverty and financial insecurity, health inequality, and evidence gaps which are there because of less clinical trials. The other side effects are the diet, sedentary lifestyle, central obesity, metabolic syndrome, and inflammation. The other important one is the reproductive, which is specifically in female, like menstrual disorder, uterine fibroids, endometriosis. All these we'll discuss later, have an impact on hypertension, or they pose as a risk factor for hypertension in females. The other one is the sodium sensitivity, like we all discussed, the RAS activation system, the endothelial dysfunction, vascular stiffness, presence of other autoimmune diseases, and early chronic kidney disease. So going one by one, so the reproductive risk factors. So it has been seen that between 10 to 30% of women of the reproductive age, they have uterine fibroids. And in so many studies, it is seen that with age-adjusted prevalence of CVD, it was seen that patients who had fibroids had more cardiovascular diseases compared to females. Even in patients who were normotensive and had fibroids, it was seen that the cardiovascular disease risk was more in females who had fibroids. So much so is with the PCOD as well. So women who have PCOS, they may present with cardiometabolic disorders like obesity, insulin resistance, hyperglycemia, dyslipidemia, hypertension, and gestational hypertension. So uterine fibroids and PCOD are a harbinger, or maybe they cause more of hypertension and CVD risk in female patients. The other one is the endometriosis, and in many studies it has been linked to hypercholesterolemia, hypertension, hypertensive disorders of pregnancy, and increased CVD risk. What happens to menarche and menstrual disorders? So both early and late menarche, they have been associated with hypertension and other cardiometabolic risk factors leading to greater CVD risk. Also, women, it was seen that women who have menstrual disorders like menorrhagia or dysmenorrhea, they have a higher risk of developing hypertension as compared to females who do not have. Also, it was seen that the girls who had Turner syndrome and who present with menstrual disorders, they develop hypertension at a young age. So, other risk factors of reproductive etiology would be pregnancy is considered to be a cardiovascular stress test that might cause or reveal hypertension and CVD risk. Adverse pregnancy outcomes, especially complicated by gestational hypertension, preeclampsia, or premature birth, they may not only lead to increased maternal or child morbidity, but they may also impact the future of the mother and child, as seen because of the cardiovascular risk which develops. So it is also seen that the CVD is seen more in patients, in females who are like nulliparous women, or women with infertility problems, or who have never breastfed, or women who experience early or a premature menopause. The social risk factors, obviously, like yesterday, Valensko ma'am also discussed that, there is so much of stigma associated with female patients going to the clinics and getting themselves diagnosed, and they have a poor outreach for the health facilities as well. Also, it is seen that women have underrepresentation in all clinical guidelines, in majority of the clinical guidelines, because of the hampered knowledge generation. Also, the responsibility they have as a caregiver, their low literacy rate, restricted mobility and finances, limited autonomy on health information, and general socioeconomic deprivation. It also creates so much of health disparities, which we see when it comes to females. So these were the certain studies which were done as a social risk factor, that the poverty and financial, because of poverty and financial insecurity, there was an increased prevalence of hypertension, especially in females aged between 25 to 44 years. Also, it was seen that the low socioeconomic status and low blood pressure, there was a meta-analysis which showed that in females who were in lower socioeconomic status group, they had a strong correlation with hypertension. So there was a study in Lancet 2021, and would seen that around 75% of the patients, be it a male or female, they live in low, middle or low income countries or group of people. And obviously, the stress factor which is there because of the chronic economic stress, it increases the sympathetic activity and cortisol level, driving blood pressure elevation. There's so many articles also available on the healthcare inequality between a male and a female. So it was in the Guardian, it was reported that that women are still underrepresented in clinical trials and their symptoms are often dismissed. There was also article written in the Financial Times that women are more likely to experience severe and chronic pain, they but often receive a substandard treatment compared to them. And in AHA also in 2022, it was seen that the women of color, they more often live in a toxic environment which might negatively impact blood pressure, reproductive health and then cardiovascular health. So many articles and studies that are there which show that the inequality of healthcare provided to the females can pose as a risk factor for hypertension. So, like we discussed, that females after the decrease of estrogen, they have so many hemodynamic changes, the sodium sensitivity, the sympathetic nervous system activity, and the difference in the RAS pathways, which leads to hypertension. Also, it is seen that in smaller studies that the women have a shorter arterial length and it causes increase in a faster arterial stiffening, steeper blood pressure increase with age, concentric LVH with preserved injection fraction. There's a greater amplification of the systolic pressure which causes microvascular dysfunction and predisposing to higher risk of CKD and cardiac complications. So again, there were studies which showed that because of all these risk factors, females experience all these symptoms at a BP of around 10 millimeter of mercury lower than men. So the increased risk of MI, heart failure, stroke, or CVA, these are seen in patients in females at a relatively lower BP as compared to males. Also, it is seen that when it comes to stroke and neurological risk, additional female-specific risk factors are there, which include migraine with aura, use of OCPs, preeclampsia, and in females, hypertension is strongly related to cognitive decline with patients, especially who have a pre-history of hypertensive pregnancy disorders. Also, the risk of peripheral arterial disease is more seen in patients as compared to males. The metabolic risk factors which are there include are also higher as compared to men, especially after the menopause when there is a decline in the estrogen. It leads to, in females specifically, it leads to increased visceral fat accumulation, insulin resistance, and a higher risk of hypertension. So there was a study which was concluded by National Institute of Medical Sciences, which said that women had 29% risk of metabolic syndrome as compared to men. And in menopausal and postmenopausal female, high BMI, low HDL, increased waist circumference and hyperglycemia all were prominent risk factors when it came to CVD. So how do we reduce these risks? So after discussing the risk, how do we reduce this risk of burden in CVD in women and hypertension? So this is a beautiful diagram and it says that there are evidence gaps and we need to fulfill them. So one is to raise the awareness, especially through the community education and prevention initiatives. Optimize the prevention and clinical care by clinical partnerships among various institutes and focusing on improving the quality of life. Support research, improving clinical trial participation of females in good major clinical trials. Engaging in community-based programs and community interventions, and advocating the importance of social stigma and social determinants of females in health policies. So few words about the
Just left,
hypertension.
ma'am. Two
Sir,
minutes.
I'll just quickly go through the slides of management of hypertension in women. So I'll just recommend the WHO 2021 guidelines, which says that the general recommendation of pharmacology should not differ between men and women except in pregnancy. Few considerations in pregnancies, like as we all know, ACE inhibitors and ARBs are contraindicated in pregnancy or in women who want to get pregnant. In preeclampsia and eclampsia, they should require urgent and specific treatment. The treatment threshold initiation should be more than 160 by 105 for chronic or gestational hypertension. However, some of the guidelines they differ and they say that the treatment should be initiated at 150 by 90 millimeters of mercury. The BP target is still debated. Like I already said, there is a debate between 150, 90, 140 and 90 and 160. But depending on the complications, patient should be treated, and the preferred anti-hypertension should be methyl dopa beta blockers and direct vasodilators. Thiazide diuretics should be avoided. These are the few other guidelines. I skipped these guidelines, and these are the this is the chart which compares more or less the other guidelines as well. One word about the fibromuscular dysplasia. It is seen more frequently in women, especially in women with less than 30 years of age. You should always analyze them for fibromuscular dysplasia. So in conclusion, I'll just conclude my slides that blood pressure monitoring is recommended before and during and the use of contraceptive pills. These are few highlights of hypertension in women. The management of preeclampsia, eclampsia should be there in pregnancy. Disparities in treatment targets of severe and non-severe hypertension in pregnancy are still observed and should be taken care of. So BP increase in CVD risk accumulation, they start in young premenopausal female, and we should target them there only. We should not wait. So premenopausal should be women should be counseled about hypertension and analyzed for the risk factors. A healthy reproductive system is central to females' cardiovascular health and as well as the offspring. In addition, female specific hemodynamic characteristics like vascular stiffness, systolic hypotension, microvascular damage should be taken care of, and these aspects of pathogenesis, diagnosis and management should be sufficiently treated and represented more in the clinical guidelines for women. So thank you so much for your patient listening.